Hello there everyone, welcome back to the channel. This is Dr. J. Today we're working on a really deep impaction all the way into an area that we call the anterior sulcus. We'll be working on the left ear. As we insert the ear speculum into the ear canal, we can see all the way to an area we call the anterior sulcus, which is bounded by the anterior canal wall and the tympanic membrane, and it's kind of tucked almost around a corner, and we're using the Fraser suction here, a number 5 Fraser suction. I tend to use a number 7 suction and a number 5 suction primarily in the ear canal, and I can go as low and as small as a number 3 Fraser suction. We have this cerumen impaction, and a portion of it is draped over the eardrum and over to the posterior canal wall, so we're just going to gently tease that up with the Fraser suction. It wasn't quite moving as well as I'd like to, so I use a right angle probe here, and it's a malleable probe, and I can bend it to whatever I need it to do. Then we switch to an alligator forceps because it's just really sticky as it's coming off of the canal wall. We'll try again here with the alligator forceps, being very careful, knowing that just deep to this and just underneath it is the tympanic membrane, and we're very careful not to disturb it or touch it. It's a very sensitive area. And we grab the alligator forceps again, just doing our best to try and get a hold of this thing to pull it out of this anterior sulcus. Here you can see we've bent the malleable probe, the right angle probe, just enough to reach around and into the anterior sulcus, just trying to gently tease up the front edge of the cerumen impaction. Here I am using the ear speculum as a base to try and bend it just ever enough to get it where I need it to go. Once you get it to the right shape that you need, then it works out really well. Sometimes it takes a few turns to get it just right. The camera is a slightly different view than what I see through my own optics on the microscope. My hands are getting just a little bit in the way here, but under my view of my microscope, I can still see where the instrument is just fine. We were able to get just behind that and tease the back side of it away from the tympanic membrane. Here we are again trying to use the Fraser to gently pull this from around the corner, and the superior edge there, the highest portion in the ear canal, we're able to gently roll that back, and we are starting to make some progress here. And being very careful, being this deep in the canal, you don't want to disturb the patient, disrupt them in any way. Any sudden movements would potentially be dangerous for them, and as a practitioner, that's poor form. Here we are trying to elevate that anterior side again, and it's just really being stubborn. And once you get into the situation where you know it's just too sticky and it's just not behaving as you want it to, at this point you make a decision on what comes next. Usually this involves some sort of lubricant or emollient. There's many different topical liquids that you can use in the ear canal that are safe for the ear canal and the eardrum and for the patient. My preference that we have here in our office is Colace. I've had several comments on why would you use a stool softener in the ear, and that's a great question. What is Colace? It helps to decrease the surface tension, decrease the friction, which makes the bowels move easier, and it also works very well in the ear canal for the exact same reasons. And once the Colace is allowed to sit for a few minutes, we go back in and just freeing up the excess Colace as well as some of the cerumen that comes off initially. And as we use the Fraser suction again, we can see that if we just elevate up a little bit, some of that Colace is able to just get in between the cerumen impaction and the anterior canal wall and the tympanic membrane, and then you can see that it starts to move. We are getting some movement there. The patient is tolerating this really well. Being very careful again not to disturb the tympanic membrane, and now we get some movement, and it's moving out of the ear canal just fine. You can see that it's kind of a semi-lunar shape, almost pyramidal, triangular shaped, which is the shape of the anterior sulcus. Usually resulted from aggressive Q-tipping, and it gets compressed and pushed back into that space. As we look back in the canal, we can see that anterior sulcus is now clear. There's still some remnants of cerumen deep in the canal adjacent to the tympanic membrane. So we're just going to gently try and tease that up, just barely lifting at the front edge, trying to find that front edge is really important. Then once you find that front edge, it usually just comes right up in the section. And here we are searching for that front edge. And once you find it, then you just gently tease, kind of moving up and in at the same time, and that motion is usually just enough to get it clear of that area. As we're finishing up the canal, this isn't my usual format for producing these videos. If you enjoyed this, please let me know. If you prefer the music instead, please let me know, and I'd be happy to hear your comments. Thank you.